Hello, everybody. Welcome to today's clinical education event. My name is Christina Moby, and I work with Extrol. We're so happy that you could be here with us today. I'm delighted to welcome Dr. Bryan Gray. He is a board-certified dermatologist and Mohs surgeon from Gray Dermatology and Cosmetic Surgery in Ohio. He's going to describe a little bit why he chose to expand his practice with an office-based radiation device. He's going to summarize the opportunities and risks he considered, highlight his patient selection criteria, describe the benefits of using a small device, and he's also going to present several cases. We're so excited to have him with us here today, and with that, I'll turn it over to Dr. Gray.
Thanks so much, Christy, for the introduction. I'm Dr. Bryan Gray. I'm a board-certified dermatologist and Mohs surgeon. We added the Radiant Extrol's device about a year ago, and I'm excited to share my experience. A little background on me. I have two practices in Ohio, and we'll kind of talk about that later, but I really enjoy helping other physicians and especially dermatologists with practice development. With all the downward pressures with insurances these days, I really enjoy sharing, tips and tricks to help with patient care and, practice success as well. So I was really excited that I got to do this presentation. Just a couple of things about what we'll cover. Already kind of talked briefly about details about my practices, considerations for adding radiation therapy, and then I kind of have, it's not like a direct algorithm, but my patient selection criteria is kind of helpful knowing how to manage these tumors surgically, as well as which patients would really benefit in the long run from radiation. Then we'll go with some cases with some good photos, and then after that we'll do our Q&A session. Briefly, again, like I talked about, two practices. So we do surgical, medical, and aesthetic services at each. I do roughly 700 Mohs surgeries per year. I do actually some locums work as well from some of my colleagues. We added our Extrol unit about a year ago. We use it both for the SRT component, or superficial radiation therapy, as well as the electronic brachytherapy, and we'll briefly touch on that. We treat about 15 patients monthly with radiation, and so far it's been great. As far as diversifying the practice, so there's growing concerns about scarring and cosmetic outcomes of Mohs surgery. They tend to be very, very good, but there's certain areas where radiation just outshines traditional excisional and then Mohs surgery methods. The cure rates are pretty high, not quite as high as Mohs surgery, and honestly, that's pretty tumor dependent. Certain tumors that are easy to access with the radiation unit probably have a higher cure rate than this, but sometimes lesions are on certain surfaces that make it hard to put the applicator on, so that's why cure rates can vary in certain studies. The Extrol unit is newer technology, and it also has a smaller footprint, and I have a good photo of it. It really fits nicely. Our room that we're currently using is not very large. Capital expenditure, this one's kind of an interesting thing for me. So we have a lot of cosmetic devices, and I'm sure if you're if ever in the market, some of these devices range from $100,000 on the low end to, who knows, upwards of $400,000. And these are cosmetic devices that take a long time to actually pay off, whereas the radiation units, very specialized units, but as far as costs go, not as high as you would think. And we're able to pay off our device in less than a year, which has been amazing. It's been amazing helping patients, and then also not putting our practice in a hole, so to speak. The reimbursement's pretty established, which is nice. You can kind of know what you're getting into as you kind of start the practice. And then I just like having multiple modalities, giving patients the option of how they want to treat their skin cancer. They're very appreciative. The Radiant Aura is a dual modality machine. Extrol as a company is very helpful and has been doing radiation for a long time. They really help support you with physics commissioning and other state regulatory issues. That's one big thing about starting a radiation program, is making sure you're compliant with state regulations and kind of learning the infrastructure to really be super successful. Like I said, I'll show a picture of the unit, and it kind of shows that it's very movable. So if you did ever have to change a room, you could definitely do that very easily. The dual modality I want to discuss a little bit too. There's two types. This unit can deliver two types of energy, 70 kilovolt and 80 kilovolt. The difference is I'm not I'm not super qualified to discuss the major differences between brachytherapy, the electronic brachytherapy, and then the SRT. But electronic brachytherapy does allow you to have fewer treatments, which can be helpful for our patients, especially who have to travel. And then the tight penumbra is also nice as well, because you can do slightly smaller margins and spare some of the normal skin. As far as my patient selection criteria, I say location, location, location. Aesthetic outcomes. So the post-radiation scars that I've seen so far, they tend to be very similar to the original biopsy scar, which is pretty appealing. You can kind of tell the patient, well, if you're happy with the scar now, then more than likely you'll be happy with it after radiation. One big thing I like to think of is, will proper repair of the defect we create with Mohs surgery be unnecessarily painful or have a long, kind of drawn out recovery? Classically, we think of a paramedian forehead flap for that. So you have a large nasal tip defect, you do a paramedian forehead flap, you leave it kind of in place where the patient looks frankly strange for about 3 to 4 weeks. And then you have to bring them back for the inset procedure, which is, you know, another painful procedure that they then have to recover from. So if you're thinking of a time course, radiation can be completed in anywhere from 3 to 4 weeks, whereas the healing process for a procedure like this is even longer. So, and it often requires multiple post-op visits as well. So if you're looking at the two side by side, even though radiation sounds more daunting simply because it's more visits, and we'll talk about that, it actually can be significantly less visits than some of the classic repair methods. So I try to keep that in mind with my patients. So painful sites. So the nose is obviously very painful for local anesthesia. I have patients that have refused treatment of a basal cell. They say, hey, if you don't have anything other than local anesthesia for this, I'm not going to do it. So that can be a pretty strong selection criteria. Some patients are just generally needle phobic anyway. So some patients are where painful sites they're not pretty good with, but some just can't even stand the sight of a needle at all. So this is a very good option for them. As well as travel is a big one. Since radiation does tend to be more treatments overall, it's important to kind of frame it to the patient as well and consider how far they're coming to your location to do the treatments. So radiation, I say, how do I sell radiation to patients? So it does take a little bit of convincing. So this type of radiation is obviously much different than classic external beam radiation. Many patients have had a family member with head and neck cancer or breast, and they have a lot of negative connotations with it. The side effect profile tends to be much different than external beam. The beam has a hard time getting much deeper than a few millimeters. So this is much different than external beam, where you're trying to, you can go through the chest wall, and there's more long-term side effects with that. The other, I don't know if any of you seen head and neck patients that have gone through radiation. A lot of times they're had to have their teeth pulled just because it completely zaps your salivary glands. As far as the SRT and EBT, no long-term side effects on the mucosa. Now, however, I did put a quick note, nosebleeds I've had happen a few times. You need to appropriately shield some of these patients, but it does recover a few weeks after the last treatment. Another good point, little to no pain with the treatments. They're very short, 1 to 2 minutes. So even though they're multiple, patients are in and out if you can run efficiently. Cons, so telling patients, hey, it may be anywhere from 7 to 21 treatments based on site. So the sites that I really like radiation for are cartilaginous. So nasal tip, ear. So those areas actually do better doing more fractionations at less power. So you hopefully to avoid cartilage necrosis. I haven't seen it yet, and that's probably because of our extended protocols, but that can be a downside. Some of these sites that were thinking, hey, this would be great for radiation, it is going to take more visits. Another con, so wound care is necessary. It's a little bit different than average post-op care, but you want to give the patient an accurate depiction of, hey, some of them barely have any wound care, and some of them, you know, you can get some moist desquamation, and you have to treat topically for these patients too. So you can't really say, hey, you're not going to have a wound during this time versus Mohs surgery, you would have a wound. You know, you can get some superficial ulceration. So I think it's important to inform patients of that. Okay, so my favorite areas for these are nasal tip or alar lesions. Even small defects on the nasal tip or the ala often require some sort of repair, whether it be a flap or full thickness skin graft, simply because these areas are very sebaceous, so they tend to retract a lot after we remove these lesions. So granulation isn't really the best option for these areas. Alar lesions can really take up the whole ala very quickly, which I'll kind of have some pictures of later. That pretty much forces you into a nasolabial interpolation flap. So having a nice option where you don't have to completely reconstruct the ala is very appealing. I also like it for the helical rim. Helical rim lesions, it's very hard to keep these superficial, and even a superficial defect will leave essentially a Mike Tyson type a defect in the ear. So these I'm often doing very complex helical rim advancement or cartilage wedge or some combination of these. These repairs, infection rates are low, but you can get gram-negative infection, especially in those diabetic patients. And a lot of times if you're doing these wedges, you do get a little, what I call an anterior deformity, where the ear is basically tilting anteriorly, and now they have one ear that's basically protruding more than the other. So I like it for those. Again, that rule of, hey, is your biopsy site aesthetically okay right now? If it is, then radiation might be a good fit because I'm not making the defect any worse. Multiple sites has really been very nice. So because there's no Medicare multiple reduction rule, at least in our MAC, by having to treat multiple lesions. So the issue with doing multiple sites in Mohs surgery is you're getting the multiple reduction rule and basically getting half of reimbursement of the second procedure. You don't really have to worry as much about that with the radiation. So a lot of places that I occasionally do 2 lesions with Mohs, I try to spread it out, but some patients can't make that happen, and we're more than willing to work with that. But that's another selling point. Hey, we could actually do both of these lesions at the same time. So even though it's 12 treatments for each, you're doing both treatments at the same time. So it's really not that many more visits than conventional surgery. Cutaneous lip, I really like this area. Even small defects will require some sort of linear repair and leaving them with a scar a lot of times through the mucosal lip. So having radiation has been really nice for those too. There are some no-go zones for radiation. I wanted to talk briefly about those. The anterior tibial area, just with venous stasis and then the bone being so superficial, it almost reflects back. So you're almost getting 2 separate treatments going in and then coming back out. So unless you're really, I've seen a couple, not at our practice, luckily, patients that were treated with SRT that are now have long-term ulcers for that they're doing hyperbaric, and not a lot of things help for it. So I would just consider not even doing it for that area. Hair-bearing skin, so it definitely can cause some hair loss, and sometimes this recovers and sometimes it doesn't. One thing that I have had is in some of your male patients that are shaved at the time, you may not really think about this because, oh, they're shaved, it doesn't really matter. But depending on, are they consistent with their hairstyling, that's an important question to ask. If, hey, I grow out my beard in winter, boom, all of a sudden you have a bald patch, you may not be super happy with you. Eyelids, they're they're achievable, but they do require corneal shields, so you do have to be comfortable putting those in. I put those in for surgery, so it's not that big of a deal, but if you're not used to doing it, it's good to get taught by someone who's familiar how to put them in. Another thing is you think of radiation as great for the medial canthus, which it is. It is great for that area, but you want to be sure. So I guess the thought process for radiation would be we don't have to worry about injuring the lacrimal duct. However, I did look up some case reports. I obviously haven't seen it, but lacrimal duct stricture can form after radiation. So this may be an area where just because you're doing radiation doesn't mean you still won't injure the duct. Complex topography, concha bowl is a good example. If you have a larger lesion here, it's really going to be hard to get a completely flat applicator into this area. So areas with a lot of changes in depth is going to be hard to completely get with the unit. Previously irradiated site, we know about that. Patient factors, you want to make sure, especially in hard to heal areas, you want to ask about immunosuppression and drugs that the patients are on. And then aggressive tumors, so thick indurated basal cells. I've still treated these, but you want to make sure you really debulk at the time of biopsy. So I know it's we're conditioned if a patient has a large lesion to basically do a partial biopsy so they don't have a bleeding sore until you get to treatment. However, if you are considering radiation, I recommend basically shaving the whole lesion off. So you're basically debulking it, and then when the patient comes back for their treatments, it's much thinner, and then we're able to actually access the deep portion where we need to. The other thing is squamous cell carcinoma I use but you don't want to use any high risk features. So I guess it depends on your pathologist. My pathologists are they don't call moderate differentiates squamous cell. They don't do that often. So now I've seen some pathologists where most of the reason I'm getting back is well to moderate differentiated. So it's good to kind of know how your pathologist grades these. It's not super uniform. But from a medical legal standpoint, it's going to be difficult if you treat a lesion with radiation or SRT, and this lesion metastasizes. I don't know if you're going to be adequately defensible at that time. So I put a quick blurb: if it's thick, you must acquit. Here's a photo of our treatment room. You can, like I said, this treatment room is pretty small. It's probably a 15 by 10. And we have plenty of room. So behind, on the other side of the photo that I didn't take a picture would be our rolling shield and kind of the controls of the unit. But you can see the unit itself is not bigger than the chair next to it. So it's very mobile. And like I said, if you had to change rooms or your radiation program got bigger and you needed a larger space, it wouldn't be hard to accommodate that. Our patient experience, so far, patients have loved it. Mild side effects, we already talked about the skin reactions that you do need to treat during, but the recovery tends to be fast. Most patients are healed up about a month after the procedure completely. And little to no scarring or deformity. Like I tell patients, if you like the way the biopsy scar healed, then you probably will like how the radiation heals too. Okay, this is a personal case of mine. This shows his basal cell nasal tip. You can see it's a larger lesion. It's probably about 2.1 centimeters. At the biopsy, you can see we definitely debulked this lesion. This is when he came for his first treatment. You can see the scar is pretty indented already. His fraction protocol was 20 fractions at, I think it was 2.5 gray. And this was his 1 month post-op visit. You can see the aesthetic result. It actually became less indented after the course of radiation. So basically just the healing process. But I just wanted to show you this final scar. He does have one tiny lesion that we biopsied here. Always worried about recurrence, right? So the issue with radiation being, hey, we don't have histologic confirmation that it's clear. So you do need to watch these lesions a little bit more closely than your post-Mohs scar. So we did a biopsy on this little papule, and it came back a fibrous papule. And you can see he has several of these on the nose. So interesting that the SRT can kill basal cell, but it can't kill an angiofibroma. So I thought that was kind of interesting. So just to contrast with our previous case, I'm going to show one of my post-Mohs patients. He also had a similar lesion, nasal tip, larger BCC. This was the Mohs defect, and from that defect, we chose to do a nasolabial interpolation flap, and you can kind of see basically we're knowing this area and transferring the skin and leaving this connected. So this stayed connected in his case he was a smoker, so he left it a full 4 weeks. And then this was at 4 weeks, the flat inset, or sorry, this is actually a week post flap inset. This patient looked like this for 4 weeks, and he came in multiple times a week for bandage changes, because you can see this area, it's pretty difficult for you to get one single bandage on. So again, I'm kind of just highlighting, even though you think of these treatments as oh, the patient's going to have to come back multiple times for radiation. In his case, he probably would have had less visits if we had done SRT. So he had a pretty good end result, but these flaps are often, you have to make them a little bit thicker because of blood supply. So he's also going to have to come in for multiple ILK sessions, probably with 5FU as well. And you can see he has 2 scars, the donor site and then his nasal tip. This was another case that we chose to do SRT for. This was the biopsy photo, and then this was first treatment. This was about 4 weeks post-op. She had a kind of a protracted recovery, but even at 4 weeks, I was surprised she's almost completely healed. And you can kind of see the borders of the tumor here. She had some redness just because she was using just some erythema from bandaging here, but I was very surprised to see this result. This size of lesion, it's kind of hard to appreciate from the photo, but 3.1 centimeters. So this would be, if you did a linear repair here, you know, it's going to be very visible in this area. So she was very happy to not have a vertical scar here. Third case, so this was a small basal cell post-auricular. So this was the biopsy photo, and this was 4 weeks post radiation. You can't even tell anything was done here. It looks amazing. Anytime I do these lesions on the back of the ear, I either let them granulate, which, especially if you're right over cartilage, is at least a 4-week process. So again, healing time versus that and radiation about the same. And this is a typical repair that I have to end up doing if I want to close it to save the patient some wound care and time. This isn't my photo, but this is typically what I would do, a bilobe from posterior, this laxity here. So he was very happy he didn't really have many side effects from the treatment. But again, this is a cartilaginous site, so we're looking probably at least 16 treatments depending on who's kind of setting your protocol. Okay, my third case, this was a small BCC on the upper lip. You can kind of see the first treatment. This was the biopsy photo, and again, she was happy with the way the biopsy scar looked. So I said, well, the radiation scar will look very similar, and you can barely see it. It actually filled in a little bit as well. She still has some erythema at 4 weeks post-op, but that fades away. She actually, you can tell she had some here. She also probably got a nice effect at treating her actinic cheilitis. A lot of times the skin neighboring it feels very smooth, and a lot of the actinic damage is gone from the SRT. So I think that's a nice consideration as well. Some of these patients have a diagnosed skin cancer, but they have actinic damage all around it. And you're like, where do I start? This doesn't have clear delineation between tumor and then sun damaged skin. So this can be a nice way to kind of pick up on everything with the treatment. This was a kind of a large temple lesion, roughly 3.8 centimeters. And he did very well. You can see this area too. I'm kind of zooming in on the photo so we can kind of see he did amazingly well. And this would be, if you were, so probably if I had taken this out, I just would have been forced to let it granulate, which is a long time for the temple. And I've had many patients have issues with bleeding because superficial temporal artery, and just with this amount of granulation tissue, you're going to have issues with wound care. It's going to be protracted 4 to 6 weeks. Your other option is to do a large repair here, which you can see very extensive for just a temple lesion. So he did very well post radiation. The other thing I wanted to point out, you can kind of see in the photo, the skin texture is very smooth. It doesn't look fibrotic at all. It's not stiff. So worst case scenario, if this lesion came back, we could also still treat it surgically. I think the mindset is, oh, radiation really makes these tumors almost inoperable after, because the skin's so fibrotic and the tumor kind of chases around the scar tissue. But all the lesions that we've treated thus far, I can say it's not that much different from normal skin. It's soft, it's supple. I would be able to easily do Mohs on these lesions for salvage if we had to. So that's another important consideration too. Quick advice for getting started. State regulations are different, and honestly, these units aren't depending. So the SRT in dermatology hasn't really, it's been around, but it's not super common. So we even had issues with our state regulators that when we got inspected, they weren't really sure how to classify the machine and stuff like that. So finding someone that's familiar with this in your state to help with that, and then just having a radiation oncologist in your state is pretty important too. I do recommend find your support staff before buying a machine. I was lucky enough, I didn't have too many issues finding mine, but I could really see if you buy the unit, it may be 3 months, 6 months before you get up and running, simply because if you can't find a radiation therapist, which can be the biggest hurdle to work, then you're going to kind of struggle. So having all of that stuff in place and ready is my best advice. We kind of hit it from the gate. So we started very quickly, but if I could do it again, starting slowly is never a bad idea. Let your processes get in place. Start with easy lesions, not complex ones, to kind of get your feet wet. And then from there, you can kind of start expanding. You know, I've even considered adding multiple modalities for some of these larger tumors, you know, putting a patient on a hedgehog inhibitor and then doing radiation as well for some of these bigger, almost inoperable spots. But definitely when you're first getting started, it's good to start slow. Again, kind of, I touched on it before, but I think the lesion debulking at biopsy is important. If you're going to consider doing SRT or EBT for this lesion, good to kind of make it much thinner by the time that they come in for radiation. It's a little bit more feasible. And then again, I kind of touched on it before, but really beware of aggressive squamous cells. That's one thing that I would still recommend surgery for. And then we use a lot of Castle testing for squamous cells. And I think that has really helped because it's helping you identify those high risk tumors. So again, try to stick with the well differentiated squamous cells, and then ones that aren't larger that could, you know, throw a Castle 2A, or I can't remember the SCC staging, but I would just avoid those tumors altogether. And one more thing I wanted to touch on briefly before we went to the Q&A. There may be some questions on turnkey setups versus self-starting your radiation program. There are several companies that do a turnkey model versus, and those models basically, they buy the machine and they take a certain percentage of the collections and they provide a radiation therapist. It sounds really nice. I think what you have to look out for anytime there's a company standing in between you and patient care and there's extra people at the table trying to get paid, you're not necessarily, it's kind of scary to me to have another entity in your practice that's basically responsible for billing all of these lesions, and they're essentially incentivized to maximize profits, not necessarily help the patient. So that's my one advice, that don't take the cheese, so to speak. Because when you're running your own radiation program, you get to help decide how many treatments and which patients you're selecting, and you can, you know, self-select patients for hardship financial things, because it's just you billing the insurance. You don't have this third entity. So they do have some turnkey setups that are probably a little bit more favorable, and smaller groups I think would be a good idea, but really self-startup's been great for our practice. So if at any point during the Q&A somebody has more questions about that, I'd love to address it.
Thank you so much, Dr. Gray, for that comprehensive presentation, particularly on the patient selection criteria. For all of you listening in today, if you have any questions at all, please go ahead and contact us directly via email at radiant@extrail.com, or you can also complete the contact form located on our website at extrail.com/radiant. Thank you so much for your attention, and we appreciate your time. Have a great day.